All right, good afternoon, and thank you all for joining us today as we continue our conversation about mental health, maternal health. And today we're going to talk about mental health and substance use as we go forward. We are expecting as many as 200 people for this call today, so we will try to move forward pretty quickly so that we can get to Q&A at the end. Our speakers today will focus on existing resources that the Commonwealth offers to new moms. And today we're focusing, as I said, on behavioral health and substance use. So issues that we discussed at our on-site and that many of you talked to us afterwards about that we understand are really important, and some really good information is happening on that front. I do want to thank Deputy Secretary Leah Mills, Assistant Secretary Catherine Zimmerman, our State Health Commissioner, Dr. Karen Shelton, and our Medicaid Director, Cheryl Roberts, for their continued work on this issue. And we will have a bunch of follow-up lunch and learns throughout the year, as well as some additional meetings that we'll announce later on. I think everyone on the call knows how important this work is. Many of you are engaged in it every single day, so thank you for that work. I think the belief is that approximately 80% of all pregnancy-related deaths are preventable, and more than half occur from birth to 1 year old. So we have an opportunity to really look at the things that drive that. And in 2018, VDH noted that mental health, such as depression and anxiety, became significant risk factors. In Virginia, 23% of pregnancy-related deaths are due to mental health conditions, including deaths related to suicide, overdose, or poisoning related to substance use disorder. So it's a really important opportunity for us to talk about things that work, initiatives that are going on both from state government and beyond state government, and to think about things that we can do differently and better in the future. So today, as I noted, we have a lot of people on the call. So this first lunch and learn will be recorded and we'll post it online on our HHR website, as well as the presentations from our speakers after the webinar. If you have questions throughout the presentations, please go ahead and put them in the chat, and we'll be answering them after the final presenter today. And lastly, please make sure that you are muted while we hear from the presenters. And when we're finished, Leah will discuss the next steps before we end the call today. So thank you for that. So I'm going to move pretty quickly since we have 4 speakers. Our first speaker is Allie Singer-Wright, and she is the Senior Director for the Virginia Mental Health Access Program, VMAP, which is a statewide initiative that helps healthcare providers take better care of children and adolescents with mental health conditions through provider education and increasing access to child psychiatrists, psychologists, social workers, and care navigators. VMAP is really a jewel. It's something that the Medical Society and other providers, as well as the state, have worked really hard on in the past several years. Allie's resume includes time at the Virginia Healthcare Foundation, where I knew her, working on trauma-informed care initiatives for the uninsured and underserved Virginians, as well as time at Comfort Zone Camp, a nationwide nonprofit organization that provides therapeutic programming for children and families. We're really grateful to have Allie join us today, and I'm going to turn it over and wish you the best. Thank you.
Thank you, Secretary Littell. It's great to see you again, and thank you for the great introduction. Let's jump in. I'm the Senior Director, as Secretary Littell mentioned, for the Virginia Mental Health Access Program, VMAP. We are starting a MOMS initiative, and in order to describe and explain what this program is looking like, I wanted to just start off and talk about the existing VMAP program, which currently is focused on providers who see patients 21 and under. And so we have 2 main components of this program, and the model is going to be essentially the same for the maternal health initiative that we're working on right now. So I thought it'd be helpful just to walk everyone through what this model looks like and how it really works in the community. There's 2 main pieces. The first is provider education. And so for our current VMAP program, this is focused on, again, those primary care providers who see patients 21 and under. We train them through several education opportunities, and our focus is to get them better equipped to care for patients 21 and under, their mental health. So they're screening, they're diagnosing, and they're learning to manage and treat those pediatric mental health conditions in the primary care setting in that pediatric patient's medical home. And so really at our core, VMAP's a workforce development initiative where we are trying to leverage that existing workforce where we know kids go to their PCPs and make them and enable them to be better able to care for the mental health of those patients. And we do that in these two ways, this education piece, and then we run a 40-hour-a-week call line. We call it the VMAP line. This is a consultation line for primary care providers to call where they can in real time receive consultation with child and adolescent psychiatrists. We have other specialized physicians like developmental pediatricians. We also have other behavioral health providers. We have LCSW, psychologists, LPCs on that line, all who are specialized in pediatrics to consult with these primary care providers. We also have care navigators on the line. This is an important piece because care navigation helps when these families and patients seeing their primary care providers need additional resources and referrals in the community, whether it's therapy or other levels of care for their mental health needs. And so our care navigators work directly with the patients and their families to help them find additional services outside of the medical home. Our hope is that these PCPs can really be equipped to manage the mild to moderate mental health conditions in the medical home, and then only be referring patients out who really need that additional care. Maybe perhaps through that we're able to alleviate some of that really intensive burden on that very limited behavioral health workforce that we all are familiar with. Next slide, please. So this is how we hope it all works together. We train providers, and then we have this VMAP line to support them. They don't have to be trained by VMAP in mental health education to call the VMAP line, but it is meant to work hand in hand, right? You train providers to be screening for things like suicidality. They're going to want someone to call when they get a positive screen to support them in next steps and make sure they're, putting their training into practice. And so provider would call the VMAP line. They're sent to a regional team who conducts a brief intake, and they really have access to one of these three services or all three, where they can consult with a physician, they can consult with one of our licensed mental health professionals, or they can ask for care navigation where, if they want, we'll actually call the patient family and work directly with them to get them into additional services. Next slide. These are the teams who work on our VMAP line. VMAP has extensive staff all over the state. We have almost 80 folks who work for VMAP in some capacity. Many of them are staffing the VMAP line out of these institutions and partners that we work with. We have regional hubs. So if you're in Charlottesville and you call the VMAP line, let's say you're a pediatrician and you have a patient who is under 21 and needs support, you would call the VMAP line and actually get sent to our teams in the Western region so that we have this kind of localized consultation and care navigation happening. We know the community needs, we know the community resources. We also have an early childhood hub that we've launched, and is one of the reasons why we've moved into this maternal health territory or area that I'll talk about in just a second. Next slide, please. Just to show a little bit as we've launched the VMAP line, we first launched it in 2019. Our calls have really increased as we've expanded and offered this regionally all over the state. It's now available in all regions. So 9 to 5, any primary care provider. This includes family physicians, nurse practitioners, PAs, certainly pediatricians can call at any time during the week and can access those consultative services and care navigation for their patients. You can see the calls have greatly expanded over the years. Next slide, Catherine. This is where we're at so far. We're about to publish our impact report for last year. We have 1,300 providers registered for VMAP. We've had almost 7,000 calls to the line as of the end of 2023. We've hit call volume records every month this year, so that number is already a lot higher, given that it's almost June. 5,600 patients served. So these are pediatric patients, Virginia children who we're serving through their providers calling the call line. And then we have 1,300 providers trained. And I just want to highlight this provider training number because with every provider that we train, let's say a pediatrician is a common provider that is trained and calls the call line. They have a patient panel of over 1,500 patients. And so through training one provider, they're able to take that knowledge and skills and actually apply it to their entire patient panel. So it's a great access point to be able to make sure all of those patients seeing that provider have a provider better equipped to manage their mental health and support them when things come up or when they are needing more services. Next slide. This is our funding. I couldn't be on this presentation today without calling out our incredible funding partners who've made this possible. We were seed funded through a HRSA grant that came through the Virginia Department of Health, and that allowed us to get up and running, and we're fortunate enough to still have that funding. And then we have been able to advocate and successfully acquire state funds. And that has allowed for our recent expansion programs, including our maternal health program. And we're actually going to be getting, as of just recently, another $3.9 million a year starting next fiscal year to allow that maternal health program to grow statewide. Next slide. So how we got to maternal health space, and I expect many people perhaps on this meeting might work in maternal health spaces, and if you're in that space, then you are naturally working with parents and people who might have very young children. We kind of entered this space from the pediatric stance where we were serving general pediatric populations, and then we started noticing a need in the early childhood space where there was excessive workforce shortages, even worse than the ones that we already are familiar with in the mental health world, an increase in demand for early childhood mental, emotional, and behavioral health services, and extensive wait lists for these families to get into care or even just to get a diagnosis for something like autism. So we also know that PCPs see children at least 12 times before they're 5. So again, that's that access point, that touch point. And so we wanted to be able to help these PCPs better manage these early childhood cases and get these families where they need to go to support them. Successfully advocated for state funds so that we could do this. Next slide, please. So through our early childhood expansion, we provide the training and support that those primary care providers need to recognize and respond to those early childhood concerns. We did this in two main ways, those two main pieces that I already talked about. We added an early childhood hub to our VMAP line with specialists in early childhood work, and then added early childhood trainings for primary care providers. Next slide. This is our early childhood line. We just launched this year, and so now when you call the VMAP line, primary care providers can press 6 for a patient under 6, and we have a set of early childhood specialists who are available to consult with them. These are early childhood child psychiatrists, developmental behavioral pediatricians. We have licensed mental health professionals like psychologists who specialize in early childhood, and care navigators who will work directly with those families to help them get into care. Again, we just launched this a couple months ago, and we have done a little bit of marketing around it, and we're getting a lot of uptake in our calls for early childhood cases. As we started working more and more into early childhood, now we're working a lot with those parents, right? The pregnant and postpartum mothers, and working with primary care providers on how they can best support them. Next slide. So that's how we got to our maternal mental health expansion. We're starting to do all of this early childhood work. Naturally, that evolves into a perinatal space. We also learned that 20% of patients report having some mental health concern during pregnancy or postpartum, but 3/4 don't ever receive any treatment. As Secretary Littell pointed out, excuse me, I have a little preschool bug that my child brought home I'm fighting today. But as Secretary Littell pointed out, we also have perinatal mental health issues being a leading cause of death. This is preventable, and most frequently, and the highest, I think, that we were reading about were accidental overdose and death by suicide. And so totally preventable mental health conditions that can be addressed, and really something that is obviously a big gap, and left untreated, leading to dangerous health outcomes for birthing people, and impact developmental outcomes of infants, babies, and toddlers, the things that we're working on and addressing in our early childhood work. Next slide. 100% of our localities are now mental health professional shortage areas, and we also know that we rank 39th lowest in the country as a state for the number of mental health specialists available. And specifically looking at maternal health care, also shortages in that space, even more so in that specialty, and then getting into maternal health care and mental health care, even fewer resources available. So some of the reasoning behind our decision to tackle this need through VMAP. Next slide. So what is this expansion going to look like, and where are we at right now? We did receive additional funds in the fall to launch VMAP for Moms Plus. That is what we're calling our maternal health expansion. And this is going to be designed for maternal health providers. So whereas our previous program has been for primary care providers who see kids patients 21 and under. This is going to be for maternal health providers who see perinatal individuals. So OB/GYNs, midwives, family physicians, really any healthcare provider who interacts with a pregnant or postpartum person, pediatricians, lactation professionals. That is who our new VMAP for Moms Plus program is going to be directed for. Next slide. We are hoping to launch our VMAP for Moms line later this year. We're going to have those same two components that I went over, our provider education and our VMAP line, essentially just replicating that in the perinatal and maternal health space. So we're hoping that our VMAP for Moms line is looking to launch later this year. It will launch later this year. And what we're going to do with that is we are going to create a VMAP for Moms Plus line that has perinatal psychiatrists, other perinatal licensed mental health professionals, and specialized perinatal care navigators on the other end of it. So those maternal health providers I mentioned, OB/GYN, family physician, can call and receive a consultation with these specialists or receive care navigation for their patients to help them connect with the resources and referrals needed. So maternal health providers will be able to call the VMAP for Moms Plus line during regular business hours and access the above services. And all of this is at no cost to them. Obviously, through our generous state funding, we're able to offer this service and be available for maternal health providers statewide. Next slide. We're also going to launch the VMAP for Moms education. Just like we're training those primary care providers to manage pediatric mental health, we're going to train maternal health providers to manage perinatal mental health. So we want them to be able to screen, diagnose, and manage those perinatal mental health concerns. We have our first training scheduled for later this year. And then providers can use the VMAP for Moms line after they've been trained so they can start to put into practice what they've learned with their perinatal patients. So after we launch this summer, providers will be able to register for this training on our website. Next slide. These are all of our funders and partners statewide. As I mentioned, we have almost 80 team members across the state. So I just wanted to give a moment to thank them. But that is all for me today. I believe the next slide is my final slide, and I hope I kept time okay. Thank you guys for having me.
Thank you, Allie. That was really wonderful. And very quickly to our attendees, we were very, very excited about this topic, and we filled our agenda today, very ambitious. So Allie has our contact information for questions. We are pretty sure we will not have time for questions today. Please email Catherine or myself or any of our folks, our presenters here with questions. But with that being said, just to keep things moving along, it is my privilege to introduce our next speaker, which is Glenda Knight, a Women's Services Coordinator with the Department of Behavioral Health and Developmental Services, who's going to talk to us about Project Link. And let me tell you quickly about Glenda. She is a licensed professional counselor and certified substance abuse counselor. She's been working in the field for over 30 years, and she's been employed with the Department of Behavioral Health since 2019 and has been the Virginia Women's Service Coordinator since 2022. In her current role, she provides oversight and technical assistance to Virginia's 40 CSBs, women's services programs, and priority population services that are funded wholly or partly by the Substance Use Prevention, Treatment, and Recovery Services Block Grant. And she's also a veteran of the United States Army and served 3 years of the Pentagon. So thank you so much for your service, Glenda, and thank you for telling us about Virginia's Project Link program. We're really excited to hear about it.
Okay, thank you so much. I am very excited to be here to provide an overview of Project Link. And I can tell you 10 minutes, I am going to keep the presentation to 10 minutes, but if you have questions, please feel free to reach out and I can do further follow-up and do additional presentation if you desire so. Next slide, please. So the overview today is just a little bit of the history, structure, mission, goals, services, as well as the oversight of the Project Link sites, as well as where they're located within the Commonwealth of Virginia. Next slide, please. So a little bit about the history of Project Link. Back in 1989, there were committee members from the Virginia Department of Health, Virginia Corporate Extension, and Virginia Department of Behavioral Health and Developmental Services, but at that time it was named DMAS, the previous title before we went the name change. These committee members noticed that within the Commonwealth of Virginia that there were gap in services for women who had issues with substance use as well as their infants and their children. This committee designed a coordinated approach to figure out how can we provide services throughout the Commonwealth that would meet the needs of pregnant and parenting women and their children, but as well as provide support to providers as well. The committee determined that this program would be called Project Link. So hence this is where Project Link, the name was identified in 1989 by the Virginia Department of Health, Virginia Corporate Extension, and also DBHDS. And with that, it would be a single entry point for pregnant, postpartum, and parenting individuals impacted by substance use. In 1992, there was a competitive RFP that was submitted throughout the Commonwealth, and at that time, 5 Project Link sites were uplifted and they were housed within Community Services Board. As of 2023, we have 14 sites currently, and at the end of the presentation, I will give you the locations of where they're located. Next slide, please. So the mission of Project Link has remained the same since 1989, although the program structure has changed over the decades. And the mission basically is to reduce existing barriers for the attending population for accessing substance use disorder and co-occurring disorder services, because we know with research that women who are impacted by substance use disorders also have a underlying diagnosed or undiagnosed mental health disorder as well. Coordinate the existing services within a community, advocacy, and also enhancing this knowledge and skill base of those providers who are providing services to these families. As stated before, all the Project Link programs are housed within Community Services Board and Behavioral Health Authorities. Next slide. So the goals of Project Link are 6, and which has remained the same since 1989. The main goal that we have for the program is to decrease the incidence of alcohol, tobacco, and other substance use among pregnant, postpartum, parenting, and at-risk women. And how at-risk women is defined for Project Link, it is an individual who may have been raised in a household in which a caregiver had or has a substance use disorder. If we look at our ACE scores, we really take those into consideration as well as whether or not an individual is identified as meeting the criteria for Project Link services. One of the goals of Project Link as well is to increase early identification of the targeted population, which includes working with OBs and prenatal providers within the community to ensure that individuals who are pregnant and impacted by substance use disorder, that they can get into services as quickly as possible, because we were looking at treating a dyad. Additionally, ensuring that those children who are delivered to women participating in Project Link, that their kids are linked to early intervention, which is Part C, and also therapeutic treatment services as well. But one of the final goals that, which is near and dear to my heart, is the Project Link, is support the optimal development of all the children in the family as well as the family structure. Next slide, please. So the mission criteria for Project Link, prior population for the state of Virginia is pregnant women who are in active substance use, who have active substance use disorder or an active use, a prior population, and they're admitted into services within 48 hours. And that is not only with Project Link, but it's with the 40 Community Services Boards as well, because we do receive the federal funding through the block grant via SAPSA. So they pregnant women, prior population, postpartum women who deliver substance-exposed newborns, prior population as well. And those referrals can come through a variety of portals into Project Link, and I will go over that briefly in another slide. Thirdly, individuals who voluntarily seek services, For the substance use or co-occurring, they can self-refer at any time. If there is an individual who has a positive screen to a high-risk behavioral health screening, and there are many assessments and screening tools out there that are utilized for this population, they can be referred by the provider to services. And finally, individuals who are mandated to services by the juvenile domestic relation court, probation and parole, or within a program within Department of Social Services. Next slide, please. Okay. So I just want to talk a little bit about substance exposed infants and the role of Project Link and the Community Services Board. So we have the Code of Virginia 127B6. Whenever there's a substance exposed infant that's delivered at one of the licensed hospital labor and delivery, and there are protocols that identifies an infant as substance exposed according to the code, then the labor and delivery, whether it is a nurse manager, whether it is a labor and delivery nurse or social worker or a nurse case manager, it depends because of the Burton Hospital. It is different individual who is the hospital discharge planner for substance exposed newborns. The referral is for Project Link. It's a direct portal. There's a substance exposed a postpartum referral form that it goes to the Community Service Board, to Project Link, and the Project Link site will perform outreach to that mother in order to get her into service and start the discharge planning at that time. So, but this is not only with the 14 Project Link site, but it's also with our other community services boards as well. It's just that Project Link has a dedicated specialized team, and they work very closely with the labor and delivery units within their planning districts. Next slide, please. So some of the Project Link services include comprehensive case management, which is what we call intensive case management services, child safety assessments when providing services within the home. Also, there are HIV risk assessment, but also the Community Service Board and the Link are also assessing the women just for sexually transmitted infection as well as part of the block grant. There's some requirements that we have, such as with Hep C, tuberculosis as well, and making sure that we provide just some preventative information for just looking at some of those health and wellness overall. Refers to prenatal and medical care, as well as transportation assistance, child care assistance to attend treatment appointments. Those are regulation requirements from SAMHSA, from the block grant. Those are requirements. So the programs have to ensure that for a pregnant or postpartum mother coming into services, that they have access to those three main services there. Home visiting, the majority of Project Link sites do provide home visiting. And home visiting service, although Project Link was identified as a home visiting program in 1989, but declassified as a home visiting program in 2015 when the funding shifted from the funding background for Project Link. It comes through the block grant. It was 80% treatment dollars, 20% prevention dollar. When SAMHSA, when we converted all the funding to 100% treatment, home visiting then became an option for the individual participating in services if they decide that it's something that they want to do. Some of the other services, emergency housing, therapeutic and psychosocial group. We have some evidence-based practices that we have implemented within the last 5 years as a result of a SAMHSA pregnant and postpartum grant that we received, as well as there are a lot of tangible and intangible resources as well. All the sites provides baby items such as diaper, baby wipes, pack and play, strollers, car seat, family event, and all of it has to do with recovery and also role modeling to the participants in the program, restructuring the family system without illicit substance and building that connection, that nurturing without alcohol and drugs. one of the other main components, which is also part of the SAMHSA and block grant requirement, is that we have to do outreach and advertisement as well for services for pregnant and postpartum women and what those services look like. Next slide, please. So as a result of the PPW grant that we received in 2017 and the no-cost extension through 2020, we implemented some evidence-based practice with Project Link, which includes the Nurturing Parenting for Families and Substance Abuse Treatment and Recovery program that is for those of us who come from early childhood of family system probably are very familiar with Dr. Stephen Babiclet and the nurturing program for all different populations. I first used the program next to work with military families a long time ago. So we were able to bring that in with funding through that SAMHSA grant. It is an evidence-based program which can be implemented within a group setting or individual setting as well. And it looks at the relational model, the continuum of care of parenting and recovery and what that looks like. It is based upon Erik Erikson's psychosocial development steps, as well as some of the interpersonal relationship models as well, with also recovery and substance use treatment. We implemented a second EBP practice, evidence-based component, because so many of the individuals coming across the Commonwealth who enter into the services had a significant history of trauma, to include complex childhood trauma, as well as looking at post-traumatic stress disorder and some of the other indicators, also intimate partner violence as well. So we allowed the program to select which trauma program they wanted to implement. And many of the boards are implementing Seeking Safety, because that can be done within a group setting or individual. Beyond Trauma, which is Dr. Stephanie Covington, who was a subject matter expert for the SAMHSA tip for treating this population, who, by the way, is coming to Virginia in September to provide us up-to-date training for this population. We're so excited we're able to get her to come, as well as TRIM. TRIM is a more costly model, and it is long-term. Additionally, peer recovery services, as a result of that SAMHSA grant, is part of Project Link program. So it's individuals who have lived experience with pregnancy, parenting, substance use disorder, and working with the families, which includes home visiting, supporting them medical appointments, as well as facilitating some groups as well. Next slide, please. Okay, so some of the services, each of the Project Link sites are structured according to the Community Services Board, and their staffing varies. Some of the Project Link programs provide all of the behavioral health and clinical services, to include intensive outpatient services, co-occurring group, individual psychotherapy. They also have linkage to right there Part C house within their community services board, and therapeutic services for their infants and their children as well. And then also all of the community services board have medication assisted treatment through the SOAR grant as well, so they're able to access those services. And for pregnant individuals, normally work with a perinatologist and specialist within their community who's able to manage the MOUD treatment if they need it, and if that's something that they want to do. If the Project Link does not provide the service under their umbrella of their program, then the program works with the providers within their community services board, or they work with providers within the community to ensure that the individual is getting the services that they need. And all of the services, just want to back up for because Project Link receives treatment dollars through the block grant from SAMHSA, all of the services are based upon a clinical interview, which includes the ASAM, levels of care, and the DSM-5-TR. So that's everyone coming into services. ASAM is going to really, it's going to be the crosswalk as to what type of services that the individual is going to receive. And then keeping in mind too that the services are individualized and person-centered as well. Next slide. Okay, so monitoring and oversight, Project Link is funded through the SUBG, and we follow the regulation and requirements from SAMHSA for the prior population. SAMHSA has specific regulation for prior population, which includes pregnant women, IV drug abuse, and that's their language, pregnant women using other substance. So that is their, I apologize. Let me wrap this up. I'm going on a little bit too long. So again, this is the monitoring piece, and the next slide. Okay, so these are all the sites of where the Project Link programs are located at. The majority of them are located in Region 1 and Region 3, with the Southwest Virginia. We just uplifted the 2 Highlands Community Services Board and Allegheny Highlands CSB in FY 2023, and we also did that through an RFP proposal as well. Next slide. We have one site in Region 4 and 2 sites in Hampton, Newport News, and Virginia Beach in Region 5. We did have a Project Link in Region 2, which is Northern Virginia, but in 2017, Northern Virginia decided to return the funding back to DMAS because they had robust funding and was going to provide services within their community and their population, utilizing the funding that they were receiving. Next slide. Okay, thank you. So I think I got through that in 10 minutes. Okay, thank you, Leah. So if you have any questions, feel free to reach out. Thank you.
Well, first of all, thank you very, very much, Glenda. I'm going to introduce Makita Lewis. She's the program manager for the Women's Residential Treatment Center for Richmond Behavioral Health. Makita is the program manager for Richmond Behavioral Health Women's Residential Treatment Center, which is part of the Women's Substance Abuse Disorder and Co-occurring Service Team. Lewis's goal is to provide a safe and supportive environment to women who are pregnant and parenting, while equipping them to manage life's challenges through enhanced treatment services. And in fact, Commissioner Nelson and I went to visit and actually had a wonderful tour, got a chance to meet some of the women and their children, which I recommend, by the way. Makita is a licensed clinical social worker who has worked over 20 years with individuals, groups, and systems in the areas of substance abuse treatment. Her experience also includes works in areas of child welfare, family stabilization, women reentry, and housing stability. Lewis has extensive experience working with individuals in gender-specific treatment who are diagnosed with substance abuse and mental health disorders. She works with several local and state work groups in the area of prenatal and maternal health. So we're looking forward to hearing you talk about the experience.
Thanks so much, Commissioner Roberts, and thank you all for having me share today during your Lunch and Learn. I'm happy to be here and appreciate the opportunity. This first slide is just a photograph of our residential treatment center, the entrance. Behind those doors is important work and partnerships, collaborations with women in treatment and children. That's where that work happens. Next slide, please. This is our mission statement, which is very important to us, to expand the availability of treatment services for pregnant, postpartum, and parenting women with substance use and co-occurring mental health disorders. This mission is our why and our purpose, and it frames the work that we do each and every day. Next slide, please. Women's Gender-Specific Residential Treatment Service. RBHA's Women's Residential Treatment Center is located on a 13-acre campus, which is called the North Campus, right in Richmond, in the heart of Richmond's north side area in the Holland Park neighborhood. And as Commissioner Roberts stated, with most visitors, once they get here, they are very surprised to see that all of this campus, all of these buildings are nestled right in the heart of the city. It's a beautiful grounds and beautiful campus. We do offer a treatment continuum, which we refer to as a continuum of care. We find that is very important that our women receive that, because we don't want women to fall through the gaps. We don't want them to have any gaps in services or treatment. When women come to treatment here, we refer to that continuum of care as a continuum or a single thread of treatment, which starts the first time they make that decision to enter treatment. And it continues throughout their treatment stay, any changes in their level of care, throughout discharge, aftercare, and even beyond. Generally, during this continuum of care, we will make a step down to different levels of treatment, which is very important because it's at those transitions that services must be in place because we don't want people to relapse. We want people to have a sustained abstinence. As you can see, we've made great strides this year. We have admitted over 150 women from all over the state of Virginia, with 85% of them having Medicaid benefits. Also provided services to 40 children during this time. We're one of few places in the state of Virginia that allow women to bring their children with them to treatment, children up to age 11. And this has been very critical to women overcoming barriers to enter treatment. Next slide, please. Women's Treatment Center provides access. That word access is highlighted because that population, the population of pregnant, postpartum, and perinatal women, is critical that they get services and get those services in a timely manner. That population is a priority population for us. From the time we receive a call from any referral provider in the state of Virginia, we are going to ask them, is your individual that you're referring pregnant? Is that person in activation? Has that person recently delivered? Does that person have a child accompanying them? And also, is that person safe? So this is a priority population for us. We do receive referrals all over the state of Virginia, as I shared, hospitals, health department, social services, all the above. We do have a full team of professional staff. And on that team, it's clinicians, counselors, all of what most residential treatment facilities have. We also are happy that we have certified peer recovery specialists on our team, because these specialists serve a very important role in that they have lived experience. And that lived experience is important to women who are here because it shows that people can recover, that I can recover, that there is hope. And several of our peers have completed treatment through RBHA, which is another jewel, because those women see these model their behavior, they see that recovery is possible, that hope is possible for them. So we are very proud of that. Slide, please. Why gender-specific service? Is that even important? Why have services tailored specifically for women? It is important, and it does make a difference, because women and men, their addiction and the way they respond to addiction and substance disorders is very, very different. Women do still today incur a lot of shame, guilt, embarrassment, barriers coming into treatment. So it's important that when women do come to treatment, they are in an environment that's safe, that they are in an environment that's supportive, that they are in an environment that does not have them to feel ashamed or have any guilt over their substance use or addiction. Having that environment where women have similar experiences and where staff are specifically trained in intimate part balance, trauma-informed methods, and welfare, child abuse, co-occurring mental health disorders is very beneficial in this gender-specific settings. So it is important, and it does make a difference. Next slide, please. The continuum of care and service access at anyone along the continuum. Again, we find that the continuum of care and providing that continuum is very, very important. That single thread is very important because we don't want people to experience any service gaps. We are that residential arm along that continuum of care. And so, as I said, women or individuals in our care here transition through their different levels of care. We have high intensity and low intensity. We have outpatient, intensive outpatient, partial hospitalization, all of those things, withdrawal management. When they transition and make these changes along their continuum of care, it's very challenging, and people get afraid. And it's a risk to their recovery and their abstinence and their sobriety. So we want to make sure all of those services that you listed are available are coordinated, are scheduled, and make sure that those individuals get those services at any point along that continuum of care. We start planning individuals' transitions and discharge planning from day one, the time they get here, so that we can make sure all of those support and things are in place. Next slide, please. Services that we provide for women. As Ms. Knight shared, we do provide best practice services, services that are research informed, and more importantly, is services that are evidence based. These are all proven methods because we want men and women, children to have the best possible chance to maintain their abstinence, to stay sober, and to have a long, long lifetime of recovery. For mothers, we do all of those evidence-based practices, seeking safety, motivational interviewing, cognitive behavioral treatment, DBT, living in balance, yoga. We have doulas who are on site. They provide medication, not medication, but meditation and yoga exercises and nutrition. All of these services, evidence-based practices, offer right here in our facility, right on site. And it's important that we offer those services here right on site so that women can continue receiving those services after they leave. Also, the environment in which they receive those services is important as well. We provide those services listed in an environment that's safe, supportive, encourage trust, bond, and connections. We definitely provide it in a framework that is trauma-informed. We definitely also start at a place of strength. We really, really always emphasize strength-based approaches and asset-based approaches because when they come in, like I said, so full of shame and guilt and feeling beat down, we start where they are. We encourage them and thank them actually for coming here and say, we've been waiting for you. We're glad you made the decision to come. So they can start to get comfortable with strengths that they have and confident in knowing that their strengths are going to continue to grow. And we do health and wellness and nutrition. And we talk about sexually transmitted diseases, healthy sexual relationships, and also parenting education. Next slide, please. Services for children and families. We provide a full gamut of services for our children while they're here. We have a children's service center that has been newly innovated and developed right on site. We call it the dollhouse. You'll see a picture of that later. Evidence-based services for those children. We are very fortunate to have RBHA's early intervention on the campus in that building. So we have therapists who come on site, counselors who come on site, all of that right on site at the Children's Services Center and at our treatment facility. This is important, not just providing those services and having access to the services, but the women get to practice those services. We are here. They get to practice those services in a safe and supportive environment because many women, sometimes they're doing these things for the first time or in a long time while they're sober. So they have anxiety, they're worried that they're doing it correctly, what if the child doesn't like me? So all of that is important that they practice the services right while they are here with our support, our monitoring, with our encouragement, so the attachment with the child goes stronger and stronger and stronger. Sometimes women come who are close to delivery. They have their newborns. We work very closely with the hospital, VCU Health in the areas. They deliver, they come back here. We provide transportation to OB/GYN appointments. We provide every piece of equipment that they need. I've never seen so many different types of nursing equipment and bottle warmers, and they didn't have those things when I had my children, and pumps and just coveralls. So you provide all of the things that they're going to need right when they are here. For the family unit, we encourage family outings. We take women and their children on family outings, the ice skating and all of that. Movies, the library, all of those things right while they're. Next slide, please. We have been very fortunate to be a designated as a residential family-based treatment facility for the Virginia Department of Social Services, where children in the custody of DSS can actually accompany their biological mom to treatment. because that has, again, been a barrier to women seeking treatment. We want to overcome every barrier possible. So we have been fortunate to receive that designation, and it has worked well. Not only are children able to come with their parents, accompany their parents, but they're also able to participate in visitation while here. We also received a care grant from SAMHSA. We're going to the second time we have received that grant. For the first 5 years, we met all of our objectives and goals and did so well. I'm going to toot our own horn that we were highlighted by SAMHSA at some of the presentations as a model program in the state of Virginia. So we are very happy to continue that grant. Next slide, please. We have a partnership with the Richmond Behavioral Health Foundation, where volunteers are on the campus throughout seasons, building planters, building flower beds, and giving car seats and strollers to our mothers, in addition to what we already provide. Those volunteers have spent hours on the campus building these things, and painting and doing beautification on the campus. It's not only an opportunity to receive these, but it's also an opportunity for us to inform and educate people from the community about substance use disorders, about addiction, how it can happen to anybody in any family, in any neighborhood, from any walks of life. But they can come here, get top-notch treatment right in the city of Richmond. Next slide, please. The foundation did provide a renovated and new playground equipment for our children on site. So we are very excited about that, and our children are as well. Next slide, please. The foundation does provide holiday gifts during holiday time, and that really does uplift the spirits of the women, children who are in treatment during the holidays, and it shows that community members care. We also received a grant recently from Elevance Health and Anthem for contingency management, another evidence-based intervention. It promotes and provides incentives for the women to encourage them to go to every OBGYN, every pediatric, every treatment group, every activity, be on time, engaged, and participate. And at the end of the week, the incentives. So we have seen a lot of motivation and a lot of excitement around our contingency management protocols. And so we are so thankful to Anthem and Elevance for that. Next slide, please.
Miss Lewis, this is Leah. And so are you on, can we make this your last slide with the promise that we're going to post?
Go ahead.
You please, I interrupted you. Please finish, and then we're going to have Dr. Shelton transition, but please finish your last slide. Thank you.
Okay. This is just a picture of our entranceway. On the campus, we have beautiful gardens and walking trail, horticulture program where women and their children participate and harvest and plant and farm to table. So they eat from the garden and meals that are prepared by our chef right side. So please, thank you for your time.
Thank you, Makita. We appreciate the presentation and all the work you do in the community. That was just fabulous to hear all the great work that's going on. Next, it's my pleasure to introduce Mandolin Restivo, Executive Director for Postpartum Virginia. Postpartum Virginia supports the mission to educate families, healthcare providers, and communities about perinatal mood and anxiety disorders, or PMADS, and provide resources to help new and expectant mothers and their families overcome anxiety, depression, and other PMADS. Mandolin herself has worked in the field of women's health and mental health for over 20 years. She is an experienced nonprofit manager and a birth and postpartum doula. She has professional experience with the Bronx Reentry Working Group, as well as director for Ramapo College Women's Center and Rape Crisis Program, as well as serving as a domestic violence intervention crisis counselor. As a doula, she served over 400 families during pregnancy and first year postpartum. She is a PMAD survivor. Mandolin, thank you so much for speaking with us today.
Thank you so much for having me in this wonderful introduction. So Postpartum Support Virginia, you could go to the next slide. We educate families, healthcare providers, and communities about PMADs, and we provide resources and direct services. You can go to the next slide. And we have a three-pronged approach to this work. The first is that we deliver direct services in the form of peer support and through various programs and care coordination. We also facilitate trainings for maternal and pediatric health providers and mental health providers. We gather communities to create on-the-ground solutions to addressing perinatal mental health through the Perinatal Mental Health Coalition of Virginia and its regional work groups. And you'll learn more about each of these services as the presentation goes on. Just a bit about PMADs. I'll go through this very quickly. Next slide. They're common. It is the most common complication of pregnancy and childbirth. At least 1 in 5 people giving birth will be affected by a perinatal mood and anxiety disorder. We call them a PMAD. There are 100,000 live births in Virginia, which means that at least 20,000 childbearing people will experience a PMAD. Anywhere from 29 to 44% of Black mothers will be impacted. Rates of postpartum depression specifically are 40% higher for Hispanic mothers, and most Hispanic mothers are never screened. And at least 30% of Native American mothers will experience a PMAD. So we know that the rates of PMADs are higher among women and people of color. And we've already said today that death by suicide and accidental overdose are 2 of the leading causes of perinatal death within the first year of the birth of a child in the US. And these deaths are typically happening later in that postpartum year. So community resources are vitally important because they are likely not seeing their providers very often during this time. You could go ahead and go to the next slide. What PMADs sound like, you can take a look at this on the presentation. There's a lot of shame, a lot of guilt, racing thoughts, feeling like you're the worst mother and that your family would be better off without you are all very common thoughts during this time. You could go to the next slide. And what PMADs feel like, there's the emotional symptoms and there's also the physical symptoms. Being tired but not being able to sleep, being fatigued no matter how much you rest, feeling dizzy, feeling nauseous, body aches. We know that women of color and those who have recently entered the US are more likely to report their physical symptoms versus the emotional symptoms of a PMAD. So it's very important to think about a person holistically and what might be going on physically as well as emotionally. You can go to the next slide. The community level impact, it's $32,000 per mother-infant dyad is the cost of an untreated PMAD. It leads to increased needs for higher level, more expensive services. Folks delay entry to the workforce or other community activities such as volunteering. We have the negative outcomes for childbearing people, babies, and toddlers, and increased risk of mental health issues for the entire family. You can go to the next slide. So our services, what do we offer folks? Next slide. Our model is that all of our services are free. There are no barriers to entry. We're not billing insurance or our clients for our services. Our services are currently offered in both English and Spanish. Our peer support and social support services are provided by trained volunteers that we train, most of who have used PSVA services before, so they have lived experience and also lived experience with our services. In 2023, we had 90 Virginia volunteers provide close to 7,000 hours of time, valued at over $225,000. And then this staff provide professional care coordination services to increase access to care. You can go to our next slide. So we do use a holistic perspective. You cannot therapy your way out of poverty. We really are thinking about the holistic perspective. What do folks need to be whole and well? So you can go to your next slide. This is a flyer that we have available with all of our services where you can request those through our website. We're happy to send them to your agency or hospital. Many of the hospitals in Virginia do give these out to their patients at discharge. Next slide. We offer a warm line. It's year-round. It's in English and Spanish. You can text or call. And we also have a partnership with the National Maternal Mental Health Hotline where we refer our emergencies to them and they ensure that all the folks who call the line from Virginia are referred back to our services to see if they need care coordination or would like to join any of our other services. In 2023, we had 684 warm line contacts, and on average, callers reported about a 30% decrease in levels of distress just from that one contact with our warm line. Next slide. And we have some stories from our callers that you can read about. Next slide. We offer support groups. We were doing virtual after the pandemic, and then we moved to virtual and in person, and now we're back to in person. Our virtual numbers did drop off. And so our in-person drop-in social support groups they're open. You can come to as many of them as you would like. It provides time for sharing, coping skills and strategies, discussion of topics, and of course, referral to community resources. And then we also offer mothers and babies groups, which are evidence-based closed 6-week groups that run throughout the year. And we offer them both in person, and we do have a few virtual of those. Go ahead and do the next slide. Client story you can read about. Our peer mentor program, we are relaunching this program. We did receive funding from the Centera Health Foundation, from the Centera Cares Foundation for this program, as well as Elevance Health also supports this program. And this is, folks are matched with a mentor who has lived expertise in PMADS with similar lived experience. They meet together weekly for 6 months. And it's a great way to increase access to resources in the community, reduce stigma, help mentees ensure that they're following their care plans, and deal with any bumps in the road as they're going through their recovery. Go ahead, next slide. Care coordination, it's totally free. In 2023, we completed 779 professional care coordinations to 625 people, a 222% increase from 2022. So this was one of our newest services. It's our most requested and growing. Next slide. Client story, which you can read about. We do offer Shalene's Fund grants, which is financial support for individuals who need extra assistance to access specialized mental health care for perinatal mood and anxiety disorders. In 2023, we approved $41,000 of micro grants to 107 folks. We primarily use this funding to help people access medication management as well as specialized therapeutic services. It can also be used for lactation services, or maybe if you really need help with getting some sleep overnight, a few nights of a nurse or a doula overnight. So you can go ahead and go to the next slide. Informational resources on our website, you can find fact sheets and our support directory that is divided by location and type of provider. Go to the next slide. And then we also offer the Perinatal Mental Health Coalition of Virginia. Everyone is invited to join this Commonwealth-wide coalition. And then there are regional work groups as we get funding in different regions to have a coordinator running that work group in the various regions. And that's also on our website. And so how to access our services, you can call or text our warm line. You can also visit our website, and there you can find our social support group schedule. You can fill out a care coordination form to receive care coordination services, be matched with a peer mentor, or receive a Shalene's Fund grant. Some of our care coordination requests are coming directly from individuals. Some are coming from providers or mental health providers in the community. So there's a broad range of ways that people access our services. And you can also find our informational resources and access our support directory online. And that's it. Wanted to get us through this quickly.
Mandolin, thank you so much for that valuable information. That was fabulous. Really, really appreciative. And once again, I think that I can honestly say that we were so excited about convening this Lunch and Learn the first time for us here in with our agencies and with our secretariat, that again, we got maybe a little bit ambitious, but we just wanted to learn. That's what Lunch and Learns are all about, after all. My apologies. We found out towards the tail end of the Lunch and Learn that our chat feature was not working. So I am really, really sorry about that. But we were hoping to have this be a little bit more interactive, but a lesson learned. We will maybe the next time around be able to have a little bit more interaction. If you all have any questions, feel free to email me or Catherine Zimmerman. I think that thank you, Catherine, for helping with the logistics, and also Jonah Roca, who has been helping me with this as well. And we also have an email address, maternalhealth@governor.virginia.gov, if that's a little easier for you all to remember. And everything will be posted. I think Jonah has posted in the chat to our hhrvirginia.gov initiatives, maternal health later on today. All of the presenters were kind enough to with their presentations, and we are recording this. So our hope is to also post the recording of this. So hopefully we will be able to have more of these in the near future, but just want to thank everyone for their time. This is just amazing, and a lot of lessons learned today, and appreciate the time that you all spent with us during your lunch hour. So thank you all very, very much. And I hope you all have a wonderful day. Please contact us if you have any follow-up questions.